8-0. All right, Chicago. Of course, the mics don't work. We want them to work. Hello, Chicago. Chicago. Throwing our videos out of YouTube. Yeah.
No, we can. We have them on here. We can scrub stuff later.
Hey, Chicago. So we're here in Chicago at University of Illinois, Chicago, and we're going to get started here with our local drivers here in 10 minutes. But we're going to start off with Carl. Carl, come on in, man. And Carl just has some Chicago pizza, whether he's going to admit it to it or not.
Actually, I am. I am. And so did you.
So did I.
You enjoyed it, right?
But you know exactly how to burn it off very quickly. Now the pizza tastes really good, and it's like expanding in my stomach as we speak, as is the cheese. So you mind telling us, what can we do now to hopefully help digest that food as soon as we can?
Well, there are a couple different strategies we can take to help digest. There's some old lore about 100 steps after every meal will let you live to 100 years. That's cross cultural. So if you keep moving, that's one strategy. After I've just eaten a huge meal. Some of the strategies I'll actually implement would be like taking in some like digestive enzymes or eating with some fruit that would actually have some of those digestive enzymes in it to help break down that food. But you're always going to have those times. I myself, I try to keep pretty good, but most of the time, sometimes rather, we're going to be in an experience like this one. I think it's really important to enjoy those times.
Are we out of battery, guys?
No, cable. Should we start that video over? I would. I think we're live, right? So.
We're live.
Yeah. So anyway, I take it. I want to make sure that I enjoy those times, and on this trip, the guys kind of been razzing me about being ultra healthy and everything, and I think it's fun. It's funny, because at the end of the day, they're going to ask for my help too, because they're going to want to know. Well, maybe the strategies later on, they're going to want to take care of everything, and I thought, They actually have. So we actually got our screens done earlier today. We actually had our cholesterol screening done, glucose done. Let's see, triglycerides, a few other health aspects that we had analyzed over at another location this morning, and that was a lot of fun. And it's really interesting to see, have the guys see their numbers, and a lot of times that doesn't happen because we just kind of joke, oh well, you know what, you eat healthy and whatever. Well, when you see your numbers, that starts to affect you, and there are a lot of different things out there that can, of course, affect your numbers. I think speaking to guys, one of the best ways to do that is with your numbers, and start to understand those. So I think it's a really important thing to, as you're going to hear today from Dr. Jamin and Dr. Cijo, that you want to go and make sure your numbers you take care of your numbers at the doctors. But as all the seriousness aside, on the joking side, we made sure to get Jamin a fantastic veggie pizza, and I did it. There was one compound that I put in there for on purpose, not like a chemistry lab, but I actually did have broccoli in that pizza. He may not have realized it, but there's a couple cool things about some of those compounds in broccoli and in some of those vegetables that were included in that veggie pizza. So I snuck some health in there, kind of clumped in all the cheese and the bread. And I was actually just reading on this earlier today about some of the cool effects of some of the compounds in broccoli and some other cruciferous vegetables. And they have, so check this out, they have effects on, they actually contain magnesium, which is sort of this wonder element, mineral right now, very popular in the health literature. And then also this other compound that actually inhibits some of the estrogen production. So what we can do is we actually can become, in a sense, more manly by eating those vegetables. And I know it sounds kind of cheesy, pun intended, but when we actually eat those really good vegetables we are actually going to get more of what we need. Magnesium, some of these other compounds that are healthful. This other compound that I was mentioning, it actually has anti-cancer effects because it blocks some of the estrogen effects. So even for women out there, yes, it's a good idea to check that out. Check out your broccolis, your cruciferous vegetables. That includes things like kale and asparagus and things like that. So what do we do when we're faced with these times when, you know what, I'm definitely going to eat. I'm going to eat that pizza and I'm going to enjoy it. So the things that I'll do, I'll make sure that I get up early and try to get in something before I know I'm going to eat a larger meal during the day. So I try to get in a little bit of a run, something like that. Just try to plan ahead a little bit, knowing that those things are going to happen. But at the end of the day, you're not going to be able to prevent that, and I don't want people to prevent that, because then that makes people that's not a fun situation to have to refuse the pizza all the time. It smells too darn good, and for God's sakes, we're in Chicago after all. So some of the other things, I've been doing a lot of reading this week, and we're going to be sharing a lot of those things on Twitter and on Facebook. A lot of the things that I'm reading about and learning about in terms of how can we increase our testosterone, how can we make sure that we're getting the most out of our workouts, how can we make sure that we are becoming optimal humans. So a couple of the other things, little tidbits that I heard about while I was reading, things about cold showers that are actually really good for you. Things regarding proper strength training techniques, so actually doing more volume as opposed to just one set, one repetition maximums. Some different effects that are happening. So if there are any questions while I'm up here from social media or anything like that, please feel free to tweet us at Drive for Men, Drive for Men's Health. Please tweet us there and see if we can answer any questions for you. One of the things that has come up a lot of the time while we're on this trip is actually we're talking a lot about cholesterol. Because it actually has so many effects on testosterone and how our testosterone is formed. I thought this was a pretty interesting question, especially because a lot of the guys got their cholesterol screenings done this morning. And in fact, I know that the FDA just a few days ago actually kind of backed down on its stance on cholesterol and saying, you know what, it's not necessarily as bad as we thought. And we are, kind of refining the nutrient requirements. But so that's going to be coming down the pike very, very soon, and we're going to have some different effects from that that are actually going to make it a little bit more pleasant to eat and not have to be so strict on some of the dietary requirements. Let's see, some of the other things that I've read this week are in regards to why would we go to the doctor? So some of the things that we've read about would be how diabetes can affect your testosterone, and having type 2 diabetes actually will cause decreases in testosterone, so you're less able to fight some of the other diseases that might come along with that. And then along with that, a decrease in testosterone will actually show itself as a decrease in your ability to combat heart disease. So you actually have increased atherosclerosis, a rapid atherosclerosis with decreased testosterone, and high blood pressure and high cholesterol. In fact, we did some basic screenings this morning using the string test. That's something else that Dr. Jamin and Dr. Cedro have had me talk about before. Some of the other things I mentioned earlier, cold water exposure is another strategy actually to increase your testosterone and take care of your boys downstairs. You want to make sure that, because they're actually supposed to be cold all the time, or at least a little bit cooler than our natural body temperature. One of the things we can do to increase toughness and increase testosterone, I actually do this myself, and it took a lot of practice to get doing this, is every morning I wake up and I actually take a cold shower, a very, very cold shower. So we're going to be tweeting out some different things throughout the week. in regards to how to become, kind of your optimal man, increase testosterone, and be, and work on strength training and do all the great nutrition things that we'd love to do and really take care of ourselves and our families. But in the meantime, we're going to start with the show. Here's Dr. Brownpot again.
All right, guys, round of applause for Carl here.
Thank you very much.
Very educated. So we're going to get started in a few minutes with our folks here in Chicago. We're very excited, so just stay tuned.
You want to say something in front of the camera?
Are you guys following us on
Periscope?
Twitter? Rapper Men's Health? Go and like it, please. Or Facebook? Rapper Men's Health? Or Instagram? Rapper Men's Health? Or Periscope? Let's start one. Wes, you want to come chat with us?
Hey,
Wait. Look at you, man. You're the epitome of Men's Health, dude. Look at you, man. Yeah, this guy is like the epitome of health, dude. No, we don't want to put him on the spot.
Nah, I'm good. You guys look marvelous.
Oh my god. Oh my god. So Carl's our physiotherapist, and we're going to be waiting 10 more minutes till the main event happens here. We're so fortunate to be hosted by University of Illinois here, and so we've been talking a lot about different tests that we can do to help predict your cardiac risk or your health risk. And sometimes we're not going to be able to get guys to see the doctor. We're not going to be able to get them to go that blood test or that blood pressure screening. So Carl, we talked a little bit earlier about this, but there is one thing that you can do in the office or at home in the privacy of your own home, and that is the string test, correct?
Yeah, it's the string test. So all we have is a very basic piece of string, and in this case, I actually tied two pieces of string together. So I guess it's cheating a little bit. But So we've all, or at least most of us have heard about BMI, for instance, your body mass index. And that is a ratio of kilograms over meters squared, so that's your weight over your height. And that's got run under a lot of pressure, a lot of fire lately, because it's not as accurate as we want it to be. In the case of, say, an athlete who's fairly short but maybe weighs 200 pounds, they're going to be classified in an obese category. They might be very, very lean, but that doesn't seem to matter according to that very simple calculation. On the other hand, it sort of misses people on the very low end as well, who might have some health effects.
We're just like pre-event stuff, so you guys wanted to wait 10 minutes, right? No, we were just filling in the time, so whenever you guys are ready, just go like this, we'll start. We're ready? Okay. All right, so really quick,
we'll just wrap this up real quick. So basically, the stream test is a better indicator even than BMI, according to some research that was published back in May. And so what you do with the string test is, Jim, would you mind standing up?
Hell no, dude, I'm going to fail that thing. You're basically your height
so why don't
and
you do
waist.
it for me then?
Okay.
All right, so we want to demonstrate this. So basically, Jamin is going to measure out my height. So the best thing to do is...
Right here.
Yes, but you're gonna.
Good.
Yep. Okay.
And
then
the string in half.
then we're gonna fold the string in half, and we're gonna see if it fits comfortably around my waist.
Carl is very healthy, as you guys can see.
So.
All right, Carl. So thank you so much.
All right.
We'll continue this later on the road. You can watch us at driveformenshealth.com. But we're very excited to have our USC colleagues start the event. So that was the pre-show, and now we're gonna get started with the main event here in Chicago. Thanks, guys, for watching.
Thank you.
Good. Hi, my name is Peter Fanner, and I'd like to welcome everyone here to the UIC Innovation Center for this event. We at the Innovation Center here, we bring different disciplines from around the university together to work on different projects, and one of our biggest departments here is urology. So urology at UIC is probably the most innovative department in the university. Craig, the department head, Niederberger, he's won UIC Innovator of the Year once in the last couple of years. So urology is a big part of the activities here at the Innovation Center. We're currently working on a dedicated R&D lab for urology, and we have at least 20 urology projects running here at any one point. Various different projects. And with that, I'd like to introduce Dr. Craig Niederberger, the Department Head of Urology.
Thank you, Peter. It is just such a delight to participate in the Drive for Men's Health. This is really a fantastic opportunity to bring attention to a really, really important area. And here at the University of Illinois at Chicago, we have an innovation center where technology meets health and meets men's health So we thought that it would be a really nice opportunity to host this wonderful event at the University of Illinois Chicago Innovation Center. So thank you so much for the ability to do this, to contribute to this really important topic, and also to the sponsors for making this something that we can share with the world. So I'd like to talk a little bit about the perspective of men's health from reproduction and male fertility. So first, I'd like to talk about men's health. Men's health is just a huge problem, and it has a lot of attention. If you just do a Google search on men's health, you can see you get 217 million hits. So people are very, very interested in men's health, and it makes perfect sense. There's a whole month devoted to men's health, and that is November or Movember. This November, remember that because it's a really wonderful way to share in something that is so important and so impactful for global health. So what I'd like to talk a little bit about is male fertility, hormones, and men's health. And what I'd like to start out talking about is something that a lot of couples don't really consider until they're into trying to have kids and having a difficult time, and that is male fertility. So one of the things that couples don't appreciate, because everyone in high school is told how easy it is to have kids, is that it can be very, very difficult to have children. And it literally is a roll of the dice. Women are ovulating every month, and yet it takes about 6 months for a couple to conceive. The women are literally getting pregnant every month, but it only happens once where the little embryo implants. And the reason for this is that human reproduction is incredibly complicated, and it screws up 5 out of 6 times. And that's one of the things that is very useful to know when you're going in and trying to have children. So who's responsible if after 6 months, a year, 2 years, the couple still hasn't conceived? About half the time it's the woman, about half the time it's the guy, and about a third of the time it's shared between the two. So one of the things that I'd like to talk about is how hormones impact men's health in male reproduction. And it's very much like the thermostat and the heater in your room. So you have a thermostat, that's the pituitary, that's up in the brain, and you have the heater, that is the testes that make testosterone and also the sperm cells. And the thermostat literally sends electricity down to the heater in the form of a hormone called luteinizing hormone, or LH. In response, the heater heats up the room, and this in the body is testosterone. And interestingly enough, all men have a little bit of estradiol, the female hormone, and it turns out to be really important, just like all women have a little bit of testosterone, the male hormone, and it turns out to be really important there too. So it's the thermostat that sees estradiol that then says, okay, the room is hot enough, I'm going to turn down the electricity, or I'm going to turn down LH. And so all of this conspires to make a sperm, because you need very, very high levels of testosterone in the testis to make sperm. One of the really interesting things is that in a guy, it's estradiol that controls bone density. So estradiol turns out to be really, really important in the male. So the female hormone turns out to be super important in the male. One other thing to realize is that it's kind of like gasoline. You have this high octane component, and that's the bioavailable testosterone. That's the testosterone that the cells actually work on. So why are male hormones important? Well, first of all, 1/6 of all men have low testosterone. 1/3 of men with problems conceiving have low testosterone. And 1/2 of all guys who don't have sperm in the ejaculate, a condition we call azoospermia, have low testosterone. So low testosterone is really important in fertility, and it's really important for overall health. And it's also something that gets worse as men age. So men's testosterone decline with age. There are many studies which identify this. The Baltimore Longitudinal Study of Aging is a really good one, and it demonstrates that as testosterone levels fall, the high octane component falls even farther because there is this protein called sex hormone binding globulin that literally takes testosterone out of circulation. So aging is associated with loss of testosterone and a lot of consequences. Problems with erections, problems with muscle loss, increased fat, osteoporosis, broken hips and back, loss of body hair, anemia, and memory loss, and others. Getting old sucks. So this is an example of something that that you can see in both men and women, and that is that fractures increase as people age. And everybody knows that after women go through menopause, osteoporosis is a really big problem, and broken hips and backs are a really big problem. But few people know that 10 years later, it's the same thing with guys, and it's the same problem. Hormones are declining, and so bones are getting weaker, and they're breaking more. So what can we do about this? Well, obviously, going back to that heater and that thermostat, we can just step in and give testosterone, and that's literally like bringing a space heater into the room. What that does is it signals to the pituitary the room is hot enough, and the pituitary says, yep, turns off its electricity, and sperm goes away. So actually, testosterone is a pretty decent contraceptive, but if a guy is past his reproductive years and wants a great therapy, testosterone can really do it. But what about a guy who is still interested in having kids and has low testosterone? And as you saw, there are a lot of those. So one of the things that we can do is we can put an ice pack on the thermostat. We can either give drugs like clomiphene or tamoxifen, which are used in women, and they block estradiol. Or we can give drugs like anastrozole or testolactone that are also used in women and in men, and they block the conversion of testosterone to estradiol. So if estradiol is too high, this is great therapy to increase testosterone and bring down estradiol at the same time. Or we could step in with just, putting some alligator clips on those wires that go from the thermostat down to the heater and give something that's very, very similar to LH, and it's called human chorionic gonadotropin, or HCG, and it works quite well to just tell the heater to make more heat. So I'd like to end with just a couple of resources that you may be interested in. One is I do run a blog on male fertility called maledoc.com. And you can follow me at Twitter. This is my Twitter handle, Craig Nee. I'm also co-editor-in-chief of a journal that's devoted to fertility called Fertility and Sterility. It's been around for about 70 years or so, and has a lot of the advances in the field published within it. And you can go to fertstrt.org if you really want to drill down into what's happening in reproductive medicine. And we also have Twitter and Facebook feeds, as well as a YouTube feed, and so I would encourage you, if you're interested, to check out Fertility and Sterility as well. But mainly, I just want to say men's health is really important. Male reproductive health is often overlooked. It is just so wonderful to be able to focus on this here. I am so grateful for the opportunity. Thank you so much.
Thank you very much. What we can do is there'll be one more presenter to present a talk, and then we'll have a brief Q&A session with both speakers, just to kind of go over some questions and any questions that arise on the social media blogs.
It is my extraordinary pleasure to introduce the next urologist who will talk about really important issues in men's health. His name is Ervin Kociancic, and he is truly a global leader in men's health. He is also the vice chair of the Department of Urology at the University of Illinois at Chicago, and is internationally known and is a leader of many international organizations in this area. And he's going to be talking about two very, very important aspects of men's health. One is prostatic enlargement and how that can affect health, and the other is erectile dysfunction or impotence, and how important and common and how treatable that is. So welcome, Dr. Kociancic.
Thank you very much. So as Dr. Niederberger just said, we are going to talk about two main issues that every man can experience in his life. So having troubles in the bedroom and having troubles in the bathroom. Let's start with the bathroom first. One of the reasons why a man can have a problem with the urination is because of this small little gland which is called prostate. It's a small gland that used to grow with the aging, with the time. It surrounds the urethra, and that's why it causes all the problems in bladder emptying. The role of the prostate is actually very related to what Dr. Niederberger is doing with the fertility issue. So prostate produces part of the fluid that the semen needs during the fertilization process. So what happened with the aging? You have that. You can see this in the slide. The prostate gets bigger and bigger and bigger, and causes some severe issues onto the bladder empty. So the bladder is made of, beside other things, of a muscle, which is actually not designed to work against the resistance. When I'm saying work against the resistance, is what we are doing in our gym. We do weightlifting because we want to have our biceps and our muscles nice and strong, but the bladder was not designed for this. And the weight for the bladder is represented by the prostate. Whenever we have the prostate, the bladder has to squeeze, and a large prostate, the bladder has to squeeze and is doing this extra exercise. And the bladder hates this. Bladder is it's a very lazy organ, wants to be just doing the two simple things: store the urine without letting you know that you have this process going on in your body, and when it's time, just squeeze it smoothly out of your body. When you have a resistance, like an enlarged prostate, there the problems are starting. How common this problem is shown in this slide here. 38 million men are affected on a yearly basis by enlarged prostate. We call this BPH. It's benign prostatic hyperplasia. Hyperplasia means that the prostate is getting bigger, and benign means that this is not secondary to a cancer, to a tumor in the prostate. And as you can see in the next following lines, the older we are getting, the more common this problem is becoming. So if you are in your 60s, you are 70% of your patients will have a problem like this. But if you are in your 80s, 90% of the patient will have this kind of problem. It's almost like saying that we were predisposed to have some problems with the prostate. Here is nicely shown how this process starts, and this process starts as early as in the 20s. So when you're 20, your prostate starts growing in time. This starts in the central part of your gland, and as the time is going by, you will have the whole prostate will become bigger and bigger and bigger, And this is on the bottom part of this picture. You will see how this enlargement of the prostate can basically make the opening of the urethra closer. So that's why the bladder is fighting against this and has to work against this weight represented by the prostate. And trust me, the bladder hates this. Bladder, it's such a lazy organ, wants to work without any fatigue. So if you answer yes to any of these questions, this is what we are asking to the patients with a large prostate. How frequently you urinate? If you have to urinate frequently, you might have some problems with your prostate. If you have to go during the night time to empty your bladder more than once, you have some problems with your prostate. We call this nocturia. As I used to say to patients, night is usually for sleeping, especially if you're in your 80s. So if you have to go to urinate more often, you have to check your prostate. If you have a sudden urge to urinate, means that you have to leave whatever you're doing and go to urinate, means the bladder is becoming the guest star of your body. This is not good. You have to your prostate and your bladder being checked. If you have pain with urination, if you have difficulty, if you have to strain a lot before you can start urinating, those are all signs of the prostate that is not behaving as it should. As the time progresses, your stream is going to become slower and slower until the prostate is going to win the battle against the bladder, and the bladder will no longer be able to empty. So we call this urinary retention. Retention means that you cannot, you retain all the urine that your kidneys are producing into the bladder. And the solution is now not only that you have to get up at night to urinate, you have to get up at night and go to the emergency room so that the catheter can be placed and we can emergency drain the bladder. So that's why the prostate has to be checked, and actually we have to treat this kind of functional problem. As I said before, this is not a cancer. You can live for 150 years with an enlarged prostate. The problem is the quality of your life is going to be miserable. And of the partners that is living with you is the same. So what are we doing? What can we do for these kind of problems? We have great medication for this. We are combining medications that are opening the bladder neck. We call those alpha blockers. It's just a difficult name because there are some cells into the bladder neck that are named alpha cells that can react to this medication, so opens the bladder neck. And we have another medication that shrinks down the prostate, which is called finasteride. That's the first one that we use. A combination of these therapies is the best option that we have for this. But when these treatments are not enough, we have to offer something more. We have to rescue the function of the bladder. And so we have intervention for this. We have surgery. On this slide you can see what the goal of our surgery should be. Make our channel bigger. And we can obtain this in several ways. We can go with an instrument inside and scrape out this part of the enlarged prostate. And we can do this with normal procedure. You will hear this name TURP, which stands for transurethral resection of the prostate. But we have more modern procedure, less invasive procedure than this nowadays. We can use a laser. With the laser, we put a small fiber into the prostate and we vaporize the prostate. So the prostate is basically melting in front of our eyes when we're doing this procedure. The advantage of this is that you have less bleeding, but it's still a long procedure. Nowadays, we have some very new minimal invasive procedure. I have here in my pocket the thing that we are using into these patients. I don't know if you can see it. I can barely see it, but this is exactly what we are using in our patients. Small anchors that we can place into the urethra, and through these anchors we are obtaining this opening of the channel. As you can see here in this animation, you can see anything because it's throwing me out. So with the procedure, we are basically placing the anchors into the prostatic urethra. The urethra is the tube that connects the bladder with the out of the body. And placing these anchors, we are basically trying to achieve the same effect as with the surgery, with the endoscopic surgery that we were doing before. Try to achieve a big open channel, but without cutting down. So that's a really non-invasive procedure. This procedure has been, I've started doing this many years ago overseas, and it's the great news that it's now available in our country as well. So we can offer to our patients also here. And at UIC, we're actually the first one who start doing it in the big city of Chicago. So you no longer have, if you qualify for this procedure, you no longer have to stay in the hospital with the catheter, with the fluid running through your bladder to prevent the clotting. You can go home right after the procedure, and the procedure takes no longer than 10 minutes. Let's go now to the most serious disease that can affect the man in after the age of 40 or 50, which is erectile dysfunction. As you can see here, that what is the erectile dysfunction is the inability to achieve or maintain an erection, and or that this erection is not firm enough to have an intercourse. And as you can see here, there are two very scaring numbers. The one is the 30 million Americans suffer from this disease. This is a lot of patients having this problem, but this is not the one that scares the most. The one that scares me is that this process starts at age of 20. So there are basically kids in their 20 having problem with the erections. That's why it's good that we have that the science advanced and the art of medicine advanced so much that we can actually address these problems. How are we addressing these problems? We have great medications that we can use for these kind of patients, and those are very well known. I'm not going to mention any name, I just mention some colors. You have the blue pill, everybody knows what the blue pill is. You have a pink pill, you have several colors for this, and they're all doing great. Great because you just take this medication half an hour prior to your intercourse, and then if everything is still working, you can have your intercourse. Now the problem with this is that some of them are very expensive, and a lot of insurance plans are not covering them. But it is what it is. For the good thing in the life sentence, you have to pay a little bit more. When the medications are not working, we have other options. It's not that your medication is not working and now you have only a good book instead of having a good sexual intercourse. We can offer you something else. And this something else goes from very simple devices like the VED, which stands for a vacuum erection device, which is basically a hollow plastic tube that you put on the penis. You suck out the air, and this attracts the blood into your penis. Then you put a ring on the base of the penis, which allows this blood to stay into the penis, and you can have an intercourse. Now, I understand this is a great device. It's less expensive on the long term than medication, but takes away all the poetry of an intercourse, because this is a big piece of equipment that you need to have for your intercourses. There's something a little bit more invasive, less troublesome than this big vacuum device, are the injections in the penis. So if we can inject some drugs, some medications into the penis, and these are going to attract this blood into the penis and provide you a better erection. Again, this is, if the first one was not that poetic for intercourse, this is probably even less poetic. So when everything fails, we do have some great other options that are basically represented by a prosthetic surgery. And we use in medicine this prosthetic surgery for many couple of centuries, I would say. When an organ was failing, when a limb was failing, we would put a prosthesis, so something that is going to replace this organ. Well, we can do the same thing with the erectile dysfunction. We are now able to place a prosthesis within the penis, and that can be activated whenever this is needed. These prostheses are very well tolerated by the patients. As you can see here, you have several components of the prosthesis. Basically, we divide them in the one that are more natural looking, like the inflatable prosthesis. They're natural looking because you can deflate them and then nobody can say that you have a prosthesis. Or the one that are less naturally looking, but easier to manageable, which is the malleable prosthesis. You have basically something into the penis that makes the penis rigid all the time. You just have then to bend the penis on the side to have the intercourse. The acceptability for these kind of implants from the patient is just fantastic. They love this. I remember I had this is a typical problem for patients after radical prostatectomy. So whenever you have cancer in your prostate and the prostate gets removed so that you can live longer, very often we are damaging the nerves that are controlling the prostate. And I remember a patient that I treated for an erectile dysfunction. He said, "I'm glad that I'm here, but now I feel like a dead tree." And we did this procedure, and he said, "I have now a new spring in my life." It changed completely the quality of the life of the patient. This is my very last slide, just to convince you that this, as our ancestor used to say, you better have a urologist as a friend, because as the aging process is going by, you will need a urologist to improve the quality of your life. Thank you very much.
You don't mind sitting on that chair? It does. It's 30, I promise. All right, good afternoon, Chicago. How are we doing? Can we have, I know we've been traveling 7 days. We may smell a little bit. You guys can move up a little bit. Come on, guys.
You guys all come closer.
Come closer. We won't take any pictures. All right, so this is our portion where we ask questions, either from the audience or our social media. And I want to thank you guys for hosting us here. And this has been very educational, very informative. And we're just very honored to be here. So some of the questions that we have are, some of our general are very specific, and we kind of pick and choose. But we'll start off with you, Dr. Niederberger. There's a lot out there about infertility supplements and things that can help boost your fertility. But overall, what other health problems can put you at risk for infertility in the future? Is it like heart disease? Is it bad eating? Or how can men today avoid needing any infertility workup down the road?
It's a great question. First, thank you so much for stopping in Chicago. I mean, this is an amazing thing. This trip that you're taking all the way from Florida up into Canada, it's an amazing thing. And so thanks for stopping in the middle in Chicago and being with us. It's really wonderful to have you. A big part of the problem is we're beginning to understand that a lot of male fertility is genetic. It's kind of weird that you can inherit something that you can't pass on to your kids, right? But that's really where the data is beginning to point. So I think for most men, it's really important just to know that a healthy lifestyle, getting exercise, doing the things that are good for overall general health are extremely important. A good diet is extremely important because the cells that are inside of the testicles are really rapidly dividing. They consume a lot of energy. So the healthier that you are overall, the healthier your testicles will be. But a lot of guys think, oh, this is something that I did. The reason why I can't conceive with my wife in my 30s is because I did something bad in my 20s. And that just is not true. It's really important. It's probably a hand that you were dealt when you were a little embryo floating in your mother's womb.
Another question we had was, how is obesity linked with erectile dysfunction?
Well, I would like also to thank you for coming here to Chicago, and thank you for this beautiful gift for the car that you're going to leave here.
Hey, we do need drivers all the way to LA, so you can join us.
We will replace with something else. We like this European name on your car. Tesla is a guy from my country.
Oh, is it? Elon is from your country?
Well, it's,
Tesla. Oh, sorry. Okay.
Continent. Nikola Tesla. So that's another great question. Obesity is the big epidemic that we are facing, especially in the Western world, especially in this side of the Atlantic Ocean, and it is correlated with erectile dysfunction, as it's correlated with any other major vascular disease. It's so correlated that it's predating the erectile dysfunction, any other major vascular accidents like stroke, like MIs. That's why we are sending these patients with ED. We are checking them for the risk factors and for to see if they have any risk factor to develop in the following years any major problem. So we should act on the obesity and prevent this, and work with our colleagues from primary care physicians, with everybody who is involved in this. Not only erectile dysfunction, also BPH is related with this. There are a lot of studies showing that there is a correlation between the high cholesterol and LUTS, so lower urinary tract symptoms. The one that I just mentioned before, the one that are triggering the consultation to a urologist. So lowering cholesterol, working on obesity, preventing diabetes is the way to go.
So how do you guys suggest, this is great, we know all this stuff works, we know all these medications work, and we know there's really good treatment options out there, but what do you think it is about guys that just don't get them, motivated to come see a physician? And we, through Orlando Health, actually did a study where we asked 1,000 men 2 simple questions. One question was, what is the make and model of your first car? Do you remember what yours was, Craig?
A Ford Pinto. Orange Ford
Pinto. How about you? Do you remember your first car?
My first car was actually a Fiat.
A Fiat.
Yeah. Which is, as I was taught when I moved from Italy to US, that stands for fix it again tomorrow. But we're doing a better job. Actually, the last advertisement for the Fiat 500 is involving one of the medications for ED.
Oh, really?
Where the pill of Viagra that this old gentleman in the central part of Italy is missing and falls into the reservoir in the tank of this Fiat 500 and gets bigger.
So we asked this question to 1,000 men, and we found 81% of men remembered the make and model of their first car, but only 50% remembered the second question, which was, when did they last see a doctor? So it goes to show that guys care more about their cars, more about technology, like these Apple Watches, and I think we're going to meet our activity level today, so we can have Chicago pizza after this. Awesome.
That's why we're standing so close.
But guys care more about their cars. So what do you guys do in your practice to get guys in and motivate them, not just to see a urologist, but to see ENT, to see their primary care physicians? Because we all know, and we're all on the same page, if everyone was healthy, we would all just go chill out and drive the Tesla and not have to work. That would be awesome. And I think that's what every physician wants, is for everyone in the world to be healthy. How are we going to get there? What do you guys think is going to be that hook to get more guys to come and see their physicians?
Well, from the fertility side, and I expect it'll be a little bit different from the erectile dysfunction side. From the fertility side, often we're seeing wives bring in their husbands, or the female partner bring in the male partner, because women are more tuned into their health care, and society generally thinks that if there's a problem conceiving, it's due to the woman. So I guess the recommendation that I would have to a guy is listen to your wife, or listen to your girlfriend, or listen to your female partner, because if they're trying to get you into the doctor, that's a really good thing. That's a sign that they are really behind you.
Yeah. Well, it's interesting. In BPH, we have exactly the same route. I remember so many wives coming with the husband in the office, say, you have to fix him because I cannot sleep. He's keep waking me up when he goes to rush to the restroom. The ED, it's even easier, because when you have no erections, you don't think a lot. You just go there and you want to fix this.
Yeah.
And you try. I was actually surprised how many young, educated guys will go to the gas station, have these magic pills, trying there, and then say, this is not working, let me do something seriously for this.
Yeah. And the unfortunate thing is, if they're young like that, they probably have some cardiac disease, something else in there. And I know we always send them to a cardiologist for an evaluation, and that's just sad that that's the first presenting thing that they have.
Yeah, I think that's a great point, and this is what we are trying to do in a setting like a university. We are trying to play a global medicine. So if I see a patient with ED, I don't just insert the prosthesis. I try to evaluate why he developed this problem, and if I find something, I send this patient to the right, internist or endocrinologist or diabetologist. Yeah. And as I said before, obesity is a great problem, and you have many patients that are going from my clinic straight to the surgeons that are dealing with obesity.
Yeah. So what role do you think social media plays? So this whole event is very social media heavy. Last year we had over 350,000 impressions on social media over one day. and now we've reached over 1 million already, and we're not even halfway done with our journey. And one story Dr. Perekhal's going to share with you, it was, I don't know if you're on Periscope or not, but Periscope is live Twitter. And we had this really amazing, touching story that we had, and we would love to share it with you guys about the power of social media.
So, as you can tell, I'm the younger partner, and so, I tend to be more tech savvy, but, so Jamin, he really is a social media guru, and recently we started using Periscope, and Periscope is a live broadcasting kind of version of Twitter or Instagram, and, when we're driving late in the evenings, there's a lot of free time, and the topics sometimes degenerate, and we tend to get onto Periscope, and initially I told them, I doubted that there are many people listening, and over the last few days, we've been using Periscope quite a bit, and this one lady got on, she's been on there a few nights, and after a few days she got on one night and just said, hey, I've been watching you guys are very entertaining, especially in the evening hours, and I managed to convince my husband to make an appointment to go in and see his doctor. But that's when it really hit me, it was more, I thought it was more of a toy or just, I hadn't really thought about its impact. But when you think about it, the reason we're driving and doing this whole thing is really to, if we can get one or two guys to take ownership and do a double take, and when they think about taking care of their car, they think first about taking care of their own body, that would be huge. And so, the story gets even better. So we were driving through Ohio, and we asked her, where are you located? And she's like, well, I actually...
She came to you're driving by my office.
That's right. She was like, you're driving by our office because we charged in a charging station in Maumee, Ohio. And her office was 5 minutes away. So we decided to make a surprise visit, a little detour. We took all the camera crews and we went and visited her. Her boss wasn't too happy about it. But it was really unique, and kind of shows you the power of social media. This is a lady that we're from Orlando. We connected with her in Toledo, and had an impact on her husband's quality of care.
But not only her husband, she sent us an email today that they have 4 receptionists at that office, and all 4 of them got their husbands to make a doctor's appointment. So we could pack up and go back home today. We've gotten our reward. But what's cool is using social media, using this car, using all this technology, we're able to engage an audience. This is not about us. This is not about any particular physician, any particular practice. It's about mental health overall. So that's our story. How do you see social media? I know some doctors are sometimes afraid of using it because of liability and everything, but how do you see it being the future of what we do in our practices?
Well, I participated in social media for many years now. I'm even younger than Sucho over there. So no, I think that it is a tool that engages people exactly as you describe. I think it's really important that people understand that when you see a doctor, you still need to see a doctor. A doctor needs to do a physical examination to really understand what your body is telling you and telling your doctor. But for awareness, for knowledge, for dissemination of information that will bring patients to the doctor. And after you've seen the doctor, for learning about what you were told in that short, often too short interaction. And social media is priceless.
Yeah. I agree. Social media are really great to educate generally. And this is a great combination with what we can do. We can reach as many people as we can with social media. We can go to the individuals. But if you want to do something on the larger scale, especially in the prevention, what social media are absolutely the way to go. And they're using it because when they come to our offices, they all know everything about us. They pre-screen us, and they know a lot of things about the diseases that they are affected by. So we have the job just to clarify some things and to help them in getting into this area.
Interesting, you mentioned UroLift. So my patient actually educated me about UroLift. I wasn't up to date on the trials out in Europe, and he actually brought it in and said, "Doctor, this is what I want." And then I contacted the company, and it was still a ways away from coming here. But we can use them as resources as well. On our Periscope feed, people will engage us and tell us about other nonprofits and send us different links to different articles. So we are all getting educated in the process as well. So it's not a one-way thing. I think it's a two-way thing.
I think this is a great example So we are using social media not only to reach our patients, but also to communicate among the physicians.
Yes.
And this is a great thing that now I can really say that I've been practicing on both sides of the Atlantic Ocean. There is no big difference.
Yeah.
So we are cross-contaminating each other, and that's a huge advantage. I remember seeing the Urolith procedure 15 years ago in Australia.
50, wow.
By the guy who invented this in Wollongong, a beautiful little spot onto the Pacific Ocean there. No? And now we are doing this here. No, that's a great thing because the knowledge has no border, and social media are helping this.
Well, on behalf of the entire Drive for Men's Health crew, I want to first thank our crew that's actually with us. There's 12 guys that are endlessly not sleeping at night driving. I want to, if you guys don't mind giving them a round of applause.
And you know, we do have one more speaker. Unfortunately, he decided to show up late. No, I'm just kidding. but we're an inclusive group, so we're gonna definitely let him talk. And so,
Save the best for last.
Absolutely,
Thank you
absolutely.
for the car again.
No, no problem.
Thank you guys for being here.
That's right. And Dr. Niederberg, if you wouldn't mind introducing our last speaker.
We are going to take a picture at the end, so don't leave. I'm going to take a very selfie.
Yes.
Am I going to be I have like 5.
And please, we'd ask. Hello. Hello. We should ask that. Hello.
So African American men have about a 60% increased chance of getting prostate cancer and about 100% increased chance of dying of the disease. Family history is very important. So first-degree male relatives, fathers, uncles, brothers, sons with prostate cancer means that the man would have an increased risk as high as 2 to 4 times of having prostate cancer themselves. We probably mainly know that prostate cancer is the most common cancer in men in the United States, other than skin cancer, and it's the second cause of prostate cancer death in men in the United States. So how do we find prostate cancer? We use the PSA test. This is a blood test, and it's extremely important for men to realize what the test is. There's a lot of controversy about the PSA test, but the way I would summarize it is that, much like with that beautiful car, if you put somebody behind that car that doesn't know how to drive, they're not going to make it coast to coast, and they're not going to do a very good job. But if you put a race car driver or an expert driver behind that car, they're going to do a great job. So with this test, I think what some of the controversy is that you need to have somebody that's interpreting this test that knows what to do with the information. Now, what's really interesting about the PSA test is that this is what's happened to prostate cancer death in the United States since the advent of the PSA test. It's gone in half. In no other cancer have we seen this level of reduction in death. And I think it's largely attributed to the screening test, the PSA screening test. So at UIC, we've come up with our own guidelines about PSA testing that we think take into account some of the new information about the test. And the important things here are that we've considered when to start testing, when to stop testing, and how often to do it. So the important aspects from this are that we've now decided that men with risk factors that I mentioned before, such as African ancestry or a positive family history of prostate cancer, should begin testing at age 40. And men that do not have those risk factors, we usually start at age 50. And we actually decide the interval at which to test based on the value of the test. But the other important thing to know is that a PSA greater than 4 is considered abnormal and is oftentimes a hallmark of prostate cancer. Now, one of the issues with PSA is that it leads to a prostate biopsy, and we've had some difficulty in the past with accuracy of prostate biopsy. I like to use a needle in a haystack analogy, because with the prostate biopsy, a needle is passed into the prostate, but a very small amount of the prostate is actually sampled for tissue. And we know there's some error associated with that. We're trying to advance that, the technology, by using MRI to give us a better look. Sorry about that. Okay. To give us a better look at the prostate gland, to see if we can't target where biopsies are done to make them more accurate. We are at UIC are researching what's called diffusion imaging, and it's sort of a next generation of diffusion imaging. And I use this analogy here. If you drop the dye into a glass of water, you see that that dye moves over time and eventually mixes completely with the water. Well, water moves through our tissues in much the same way, and water moves through cancer differently than it moves through our normal prostate. So we're taking advantage of these physics with a next generation of diffusion imaging for the prostate that we think is going to be able to provide us accurate targets for prostate biopsy, and so that's what we're currently researching. The way we do that is here, as you can see here, is an example. This is a piece of the prostate that's been removed with robotic surgery. This is an image from the MRI. And then we compare that to how it looks under the microscope to try to perfect the technique. And we fuse the imaging together, the ultrasound and the MRI together, in order to aim the needle and the biopsy at the target. And the key is coming up with the good targets. So we're trying to innovate on the imaging side to know exactly where the bullseye, so to speak, would be in the prostate. So in summary, what patients should know is that they should know their risks for prostate cancer. They should be proactive in their health. They should understand their options and seek information about the disease and about the diagnostics and the treatment. And I think what we think a really good way to do that is to get them involved in research that can not only give them access to new technology and hopefully better technology, but also helps us understand the disease and helps other men. Thank you. Any questions?
One question we always get is about active surveillance and genetic testing, whether if you think there's any role for it. I think MRI biopsy is going to trump all that stuff that we do, because we're going to get a lot more focused biopsies. But even then, if we do have someone that's going to be in low risk category, even after we use all this technology, do you see a role for genetic testing? I think there's a few studies out there right now. How do you utilize that in your practice, and how do you see it changing our management as urologists?
That's a great question. I think I think active surveillance and probably MRI have the real promise to rescue some of the problems that we've had with prostate cancer detection. So active surveillance and monitoring the low-grade indolent cancers that we think take 20 to 25 years to cause a problem, I think is a very important part of the treatment paradigm now. I use MRI to monitor men on active surveillance and hopefully reduce the number of biopsies they may need. Genetic testing is definitely exploding. Technology is getting a lot better. We're running a trial at UIC that we're about to open, actually testing how a genetic profile of the tumor affects treatment choice. We're about to start that trial here in the fall. It's sponsored by the Department of Defense. So that's using the Oncotype DX assay. There are several others available too. I think that show a lot of promise, that may show us how that cancer may behave before it actually does, and it may give us more confidence and reserving aggressive treatment for those men who show a signature of their tumor, sort of personalized signature, if you will, that shows that has potential to advance.
We've met a lot of men on the road that are like, you're recommending PSA testing, because we talk a lot about prostate cancer because we have 10 days, so we end up talking a lot about the things that's near and dear to our hearts. And we get a lot of on our Periscope or social media. They say, "Well, I thought the government said no PSA testing." Now, what is your recommendation? You're trumping what the U.S. Preventive Task Force has said.
It's a very interesting issue. We feel when we put together our guidelines for our institution, I brought together not only urology, I brought folks from our public health school, from our pathology research department, as well as our primary care. And I think it's really important that we had that dialogue with a variety of physicians and researchers that see this from different angles and give the literature a critical review. So, the Preventive Services Task Force did downgrade PSA testing, and I think it was based on 2 very large screening trials that showed conflicting results. The European trial showed a benefit in mortality from PSA screening. The U.S. trial did not. There were some issues with the U.S. trial, we feel, with contamination, PSA testing in men who were not supposed to get the test. And we think that influenced the results. However, we definitely took that information into account when we made our guidelines. I think some of the exciting things about PSA testing are with the early baseline concept. So we found in our data and also in others that an early baseline PSA in a man in their 40s that's less than 1 separates about 90% of the men who would ever die from prostate cancer. So what we think we can do with that information is maybe start a strategy where we do test earlier, but we don't test as often in men who seem to be in a safe zone. I think we get into some trouble with over-testing, repeat testing, and reacting to small changes in the number and acting on that. So we want to start early, test less often, and definitely we dismiss men from testing at age 70. Okay. So we don't do aggressive treatment on men that may just not benefit from it.
Thank you so much, sir. Thank you for coming and your time. And
Thanks,
does anybody else any questions? Or otherwise, put your makeup on. Let's go take a picture in front of the car here. Thank you very much, sir.
So we're gonna do, I guess, 2 sets of pictures. With the first picture is just the entire group. If we can have everyone gather around the car. And Harry, which direction do you want to take the picture from?
I'm going to stand the car on the stage, and we get everyone sort of around the front here and then around the back.
Okay.
So like looping from the front right headlight to the back left tail light.
All right, guys. So we're going to have everyone start from this corner, and then we'll do the residence picture on that side here. All right, guys, so if we can have everyone gather around for the group picture. Hey, guys, if we can have everyone gather around. You guys, we need your help.